Welcome. I'm Hugh Davis. I was a pediatrician. I've retired recently, although maybe once you're a pediatrician for life. I don't know. It may be a life sentence. It may not be. I'm going to lead this session. Its success is by whether I talk as little as possible, and we really want you to talk. If I might take these, just say, we also are presenting of Bob Phillips, who will be able to introduce himself when he has a slide to talk about, and Jenny Preston, who I think you've met already. So to save time, I don't think we need to go through the sort of reintroductions. What we want to talk about is assessing what I've described really as the ethics of a research proposal involving children. Really, that means, what does good research look like? How can we see that any research we do is of a high standard? And what we're going to talk about is just a little bit about a framework that maybe we could all share. And this is not the property of a reviewer, regulator, researcher, patient, public, whoever. This is something that we could all share to work together. But first of all, what I'd really like to say is that, please write down your concerns and your questions in the chat box at any time. Start now. One of us will read them out and we'll put them in when relevant. And we will have a question and answer session toward the end to review all these. And I hope that this question and answer session will be the main part of this presentation where we can address your questions. We don't really know our audience very well. We've sort of been to the pre, but we don't know your particular problems. So if you've got problems or ideas or solutions you'd like to share, then really this is the opportunity. And as I've said at the bottom, if we don't know the answer, we'll try to find someone who does. Our aim is to help promote and facilitate research involving children in their area and in their community. And the method really will be to open a discussion as to what does good research involving children look like? If we're assessing something, if we're designing something, what does it look like? And as I said, our method is to engage with you, our audience. So I'm going to start really with quite a busy slide, so I'll leave it up some time and ask the question, what is fair research? And I believe you can say fair research requires an answer to these 14 questions. Is there a justifiable purpose to the research? And is it very, very clear? And that's often the stumbling block. I sit on an ethics committee, and it's quite clear sometimes the researchers or the applicants don't have a very, very clear idea what their true purpose is. It can be varied, but they should have a very clear idea. So if you're designing a study, if you're thinking about a study, if you're questioning it, say, what are you trying to do? And you could sort of say, at the end of it, so what? The second point is the study built on what's known already? And this is crucially important. Has anybody looked at what's known already, done a literature review, and said, no, this question hasn't been answered before, it needs to be answered? And it's stunning how often, actually, this isn't the case. Will the study provide meaningful information, information of value? And that's information of value to everybody. And I was listening to the earlier session, and that's meaningful information for parents, for children, for professionals looking after children, for anybody who's involved in children's care. So information of value. And the best way to find that out? Ask people. Ask the patient, ask the child, ask the parent, ask the professional, ask everybody. And the important word, it should be a partnership. PPI is really a partnership with everybody who has a vested interest in research, and that's most people in the end. The fourth question is, will it produce valid information, information that we can trust? There's no point a study producing information that's questionable. And that's quite technical and may involve statistical consideration. Is the research team equipped to complete the study? Have they got the resources, the expertise to see it through to the end? And I put down number 6, and I think this is an important point that came up before. Does the research incorporate public, patient, participant views? Is the selection fair? Are we sure that we're not excluding people unreasonably? And are we not including children unreasonably? Are they recruited fairly? And is there a fair balance of benefits and harms for all with an interest? And that's a central part of what we look at. And then point number 10, our participants offered a fair choice. It's a tenet of research, of really most things in life, that people should be able to decide whether or not they wish to do something. There are exceptions, but I think to start with, fair choice, and that's informed consent. And here there are particular differences for children and adults, and I might come back to that. Is personal data handled appropriately? Is there fair payment and payment for participation, recompense for injury? I think that was questioned earlier in the previous session. Do the participants receive acknowledgement and appropriate care after the study? And crucially important, will the project be registered and placed in the public domain? Research is an open activity, and when the results are complete, when the results are in, they should be available to everybody, for people to check the study, to audit the study, to build it, to build care, etc., etc. Now that's quite a complicated slide, but I'll leave this here and you can have the slides. That's just a sort of set of questions that I think we can say, well, this should frame our consideration when we're thinking about research, designing it or reviewing it. And I suppose the question then is, well, it's not really very different from any other research. And this is where I sort of, maybe I'm being slightly challenging. All these questions, apart from the consent issue, really apply as much to research involving children as research involving grown-ups. And therefore, I think we can learn from each other. I think we can teach adult people, adults things about research, but we can learn from them as well. And so there is a huge overlap. So let us share this together, both in the adult world and in the pediatric world, but recognize where there may be differences. And then we'll have to explore them. And as I said, I think the particular differences are in how we ensure that there's fair consent, and that the child, him or herself, is involved up to his or her capacity in that decision. That's really all I was going to say about that. And I was going to move on to Bob, and I'll hand the microphone over to Bob. What does this mean for research involving children? And Bob, I would just say, if you want, I'll give you your slide, and then when you're finished, let me know, and we'll move on to the question and answer.
Thanks, Hugh. If you want to knock it back for just 1 second, that would be lovely, and I'll ask you to knock it forward.
Yep.
Thank you. So hello, everyone. My name is Bob Phillips. I'm a part-time paediatric oncologist, so I look after children with cancer. I'm an academic, the other half, doing work primarily around evidence synthesis, and then doing studies that lead on from that. My own particular area is in supportive care in cancer, so looking not so much at the anti-cancer treatments, but all the other stuff around it: pain relief, infection control, stopping people being sick, those sorts of things. If we think about those 14 questions, for me, from the sort of clinical side going forwards, I always look at the studies that come through related to children with a really sort of, is this actually meaningful? Is it a real question that they're asking, or is it a bit of garbage? And then the second thing is, have they actually looked at all the evidence that exists in the first place? Or are they just doing it because they want to do a study rather than what they're really doing? And we'll sort of particularly look at children's studies along those lines to say, is it really a question that needs to be asked in a group of children? But when I'm doing my ethics panel stuff, sitting there, not so much doing the research, but seeing stuff that comes forwards, my role on our ethics committee is to be really awkward and annoying, and generally turn around to every researcher that turns up and go, why have you excluded children from your research? Why are you, heartless research individual, obsessed with adults, not thinking about the poor children that could benefit from you? And then if we move on to the next slide, I sort of think we can let people get away without researching on children if they have something that I've nicked from my wife's previous professional career. So in the UK, there's this thing where if a company takes over another company, they have to employ all of the people from the first company. And there are human resources professionals, which is what my wife was before she became a midwife. human resources professionals who have to employ everybody else, except if there are specific reasons why not. And these are known as the Eto Defenses. Now, this isn't about stealing companies and becoming a multinational corporation. What this is about is thinking, is it ethically reasonable? Is it practically reasonable to exclude children from your study? And maybe the researcher can come back to you and say, well, yeah, it is actually. We're doing a study looking at a new drug in heart failure. Now, heart failure does happen in children. It does. But a new drug, maybe only 1 in 1,000, 1 in 2,000 patients with heart failure is a child. Maybe it's just not reasonable to formulate the medicine in a way that a child can have for the first time that you're using it in any place. Maybe there's a technical defense. Maybe you call it respiratory distress syndrome, but when you have that and you're 30, 40, 50 on an adult intensive care unit, that's a very different disease process than if you're -3 months, -2.5 months on a neonatal intensive care unit. So it might have the same name, but actually the way it works, the pathology of it, and therefore the way that you would treat it might be strikingly different. And so that would be reasonable not to include those patients in there. Or it might be that the drug is handled extremely differently in children and in grown-ups, and that is a good reason why you shouldn't be doing the same thing in both places, and you need to look at doing it differently. There may also be just a very straightforward and simple approach that this is a single centre study, it's in an adult unit that does not see anybody under the age of 18 or 21 or whatever it is. We won't see anybody to open this study up for children. And that seems like a reasonable defence in those lines as well. The ones where I have the greatest problem are those that say we're making a cut-off at 18, even though we see in our unit patients going all the way down. We think that things change after puberty, but we're still going to make a cut at 18. And that might be that they have a misunderstanding of the legislation. For us in the UK, for clinical trials, the switch is at 16, not 18. It might be that they've never really thought about it. It may be that they're terrified of talking to teenagers. And that's understandable, but it's not an ethical defense to not doing research. And there have been occasions, not that many, but there have been occasions where researchers have taken that and gone away and come back and said, no, actually, we think you're right. We should be including this. And they've expanded it to allow the teenagers to enter. Doesn't usually then push them down into the pre-pubertal age ranges, but they have taken these on board and changed things to make it more valid to be done in children. You lot don't need persuading that research in children is a really good idea. Other people do sometimes. And the reason that research in children is necessary is the same reason as researching with everybody else is necessary. Because if we don't, then we make guesses. And as we've all seen in the global pandemic, the guesses as to the miracle medicines that were being touted in March and April have turned out largely to be garbage. And the very cheap, underserved medicines that we didn't really think would work are the ones that have come through. Now, it isn't always that way, but without the research, we're only basing it on guesses, and guesses are wrong, and they're often wrong, probably half the time. Right, I'm going to stop talking now. Thanks you.
Thanks very much for that. I'm going to miss this because we haven't really got time. Unless, well, I won't miss it. Bob, what's your one key remark you'd make, Bob, in answering that question?
Pester them. Tell them why. Why are you excluding children? Why aren't you working in our area?
Okay, Jenny.
Sorry, I was on mute. I would say, yeah, you've got to work with the patients and families.
Okay.
End of.
So use the 14 questions as a framework, pester them until they want you to go away, and get clone Jenny. That's Bob's answer. We'll have to clone Jenny without her affiliations for Liverpool Football Club. Thank you very much indeed. On these slides, and the last slide, there are some references, but there, thank you very few, that's the end. Thank you very much for all your contributions. I hope you found it useful, and I hope you enjoy the rest of the meeting.